Good afternoon, everybody. Thank you very much for joining us for today's fireside chat with some of our leadership team here at HealthMonics and our friends at chirpybird. Today, we're going to be going over insights on the future of the quality payment program based on the 2021 final rule. We have Lauren Patrick from HealthMonics. We have Saritha Curry from HealthMonics. We have myself from HealthMonics, and our friends at chirpybird, we have Joy Rios. Welcome to our fireside chat today.
Thank you, Stephen. And to provide a little bit more clarification, so for 2021, the QCDRs qualified registries are required to include comparative information in their quarterly.
I'm hearing a question. Hold on a second.
We don't have to, but QCDRs and qualified registries are.
There you go. Sorry about that. I've muted everybody. We'll get to questions at the end of the presentation. So just for everybody's knowledge, you'll be able to see over on the right-hand part of the screen, there's a section to ask questions to our panel. We have some prepared questions, but this is going to be the start of what we're looking at, and you'll be able to ask your questions right here, as well as on the bottom part of the screen, you'll be able to see handouts. I have a number of handouts on 2021 MIPS reporting information, and you'll have our contact information at the end of the webinar as well. So without further ado, I'd like to actually reach out to each one of our presenters today and ask them what they thought of the 2021 final rule. Just give me a little synopsis of where you think it's leading us right now. So let's start off with Saritha.
Where we think it is leading us. So I think the most significant thing that I took away from the 2021 final rule is that we are full steam ahead with MIPS reporting. So for the past few years, of course, we started with an intentional progressive increase of performance requirements to meet sort of the minimum for reporting requirements for each program year. But we've also seen, so some of that's intentional, but we've also seen setbacks because of COVID, the combination of which and the fact that MIPS is a budget neutral program means that no one has really felt the full weight of MIPS reporting or not reporting for good or for ill yet. So 2020, we had initially expected would be that 2019, we initially expected would be that first sort of robust experience of either penalty or reward for doing, for not reporting or for, say, exceptional performance. We really didn't feel that, and I think, clients of ours have certainly indicated that they're less than thrilled with the outcome of that payment adjustment and that those reporting years. But I think that's really changing. It'll change in 2020, and it's going to change in 2021. So there's no, in case anybody was thinking there was a reset of the program in lessening the requirements or not moving forward with APMs or not moving forward with MVPs, we really didn't see that. So I see that as CMS is doubling down on the trajectory of the program in the way that we anticipated, but we're not sure of until 2021.
Sure. Thank you very much for the Joy. Following up with that, what are you telling your customers and the people that work with you about 2021 and what that final rule told you?
Well, a couple things. One, for the first few years of the program, we often heard that people weren't going to pay as much attention to it because they thought it might be going away. And I think as the years progress, to Saritha's point, it doesn't seem to be going anywhere. So one thing that is on my radar is that every 5 years, CMS releases their 5-year strategic the Federal Health IT Strategic Plan, and that gives you some insight into what's the vision here. Where is it that we're headed? And the 2020 to 2025 plan was released a few months ago, and it just made it absolutely clear that the move to value-based care and a focus on value remains a high priority. So that coupled with the final rule just makes me feel like it's here to stay. This year in particular, to Saritha's point, you know, it's going to be more difficult. Like, people that have not started before will have a hard time achieving a higher score if they're just getting started now. We're starting to sort of reframe our message to clients, because it used to be that we would say things like, oh, we want to maximize your incentive, which of course we do, but with the penalty avoidance score being so high this year, we're now kind of reframing to like, we want to minimize whatever losses. Like, in addition to, you know, we want you to get the best score possible, but there's folks that may have been used to getting a score of 50, and that was enough to avoid a penalty in the years prior, and now it's not. So just kind of getting people in the frame of mind that they are going to have to work harder to get a higher score, and they're going to need to get a higher score in order to avoid a penalty. So that's my overarching theme going on right now.
Oh, Lauren, you are on mute. Hold on. There you go.
Oh, you muted me.
I muted everybody.
So to build on what Saritha and Joy said, I think that both of those things are true. I think that CMS is not really taking a breath for 21 or 22, but beyond that, they're really trying to push everyone into more of a value-based program, more of a program where you're comparing apples to apples with the MVP program, more of getting into actual value-based care. They're trying to align measures. You know, one of the big burdens for everybody is the fact that there's so many different measures, quality measures in these different programs. So they're really trying to align measures. The other thing that comes across loud and clear is the focus on the patient. I know Seema Verma is gone with the prior administration as of tomorrow, or I guess maybe she turned in her resignation last week. But that was always one of her big initiatives, and I think it will continue to be an initiative, is really looking at the patient and putting the patient in the center of everything. So as we move to MVPs, as we try to move to new APMs, as we look at what measures are being developed, CMS doesn't want more process measures. If you're going to put together a measure and put it forth, it really needs to be oriented towards patients. And with the new MVP program, you know, as they talk about the foundation, one of the foundations is patient focus. And there's been a lot of pushback from organizations about what does that really mean. And so I'll stop there because I don't think you wanted me to take the whole hour to.
We definitely wouldn't mind. We'll sit back and relax, and you could definitely take over right there for sure. Up on the screen, you'll see that we talk about the APMs and MVPs that Lauren was leading into. And I think what's important for everybody to understand is to build on what they're saying is that the program is evolving, and it's evolving into an area where they're bringing everybody almost into the MIPS score. And you can see these APMs and these MVPs are where the business is going. So what Lauren was saying, that they're trying to move everybody into the APMs. So now they introduce this new performance pathway, which really aligns directly with MIPS. So they're trying to bring everybody together so that there's less confusion and people can report and just think about reporting instead of where they fit and how they fit into a certain program and so forth. And that's really what these programs are built for. We're excited because it opens up an opportunity for us to really dive more into quality patient quality of patient care across all spectrums, and we don't need to worry about what type of doctor's practice that you're working at or what type of hospital. Everybody's going to really need to report for these measures moving forward, and they can work with us to figure out, do they need to do multiple categories and report through multiple areas and stuff. They could all do it in one place now instead of having to go all over and use multiple vendors and so forth. So my next question to the team is, how do we see the final rules impact on your bottom line? So, there's the quality side, right? There's the important parts about taking care of our patients and taking care of how we are tracking quality measures and so forth. But in the end, a lot of it comes down to the finance. What is going to be the impact to your bottom line, and where is that going to go? So I'm going to switch over to this screen, and I'm going to throw this one right at Joy this time. What do you think when it comes to the bottom line and what we're doing here with these programs moving forward?
Well, I mean, like I'd mentioned earlier, that penalty avoidance of, it's incrementally gone up every single year, and this is the highest that it's ever been. So considering that people are going to have to work harder and your score is directly tied to your reimbursement rate, like making it a priority to get the highest score possible, obviously, is going to be priority number one. I think that it can't be ignored, the fact that it's a budget neutral program. And when we consider how many people have actually been able to avoid penalties, and especially considering 2020, like that is definitely a concern for the program. There's a lot of folks that have opted to take that hardship application for COVID, either just for one category or potentially for all categories. So with folks not getting penalized, that leaves less in the pot to then redistribute for incentives. And remember, I always try to help people remember that there's that 2-year lag. So what people are submitting for 2020 is affecting their 2022 reimbursement rate. So right now, when we're talking about their bottom line, we're thinking 2 years ahead. It's going to be, what can you look forward to your reimbursement rate being in 2023? So, I mean, it's at the maximum. We've gotten to the 9% in either direction. I think that it'll probably be more of there's more of an incentive now for people to try to reach that exceptional performance threshold, because then at least they get guaranteed additional incentive instead of like that's kind of outside of the budget neutral aspect of the program. But it's also really important for people to know, I mean, kind of what you have on the screen here looks like an ROI calculator. So knowing how much your Medicare spending is and being able to anticipate, what your score would be, what's the anticipated reimbursement rate of that score, and kind of gauging from there how it will impact your bottom line. I think it's helpful to know if people can actually visualize, what their circumstances are going to be based on their patient population and the types of visits that, that they encounter on a regular basis. But I'll stop there. Lauren or Sarita, jump in.
So I think there's two other aspects to it. Is not only is it impacting the reimbursement from Medicare fee-for-service, but we're seeing that a lot of the MA plans are also picking up these numbers and starting to use them in some of their reimbursements for those outside networks. So that needs to be looked at as well. And then the third component of it is really attracting patients. CMS is combining, there's been physician compare and hospital compare and SNF compare, and CMS is really pushing towards moving it all together. Now it's a provider compare website. They're making it easier to use. They're putting more measures on there, and patients are paying attention. And I just read this interesting article on Health Affairs saying that patients will pay $2,000 to $3,000 more for care that from a 4-star versus a 3-star provider. So when you start looking at not only your financial, what you're getting back from CMS for every claim, but how much business you can attract. We're seeing more and more impact there as well. So I think it is, it's not going away, and folks are starting to pay more attention to it. I think that telehealth has made people more computer savvy. There's more people looking around, poking around at ratings. And so I think that the impact will continue to grow.
Right. Lauren, it actually reminds me of a story. Joy's counterpart Robin used to say back in the day when we were consulting, and that, people didn't think much of the physicians compare. But then you say to someone, you have to take your mother to the hospital, and there's a hospital that's 5 blocks away and a hospital that's 10 blocks away. And the hospital that's 5 blocks away only has 2 stars. And the hospital that's 10 blocks away has 4 stars. Which one are you going to take your mother to if it's only an extra 15-minute drive or an extra 10-minute drive, even if you have no idea what those stars mean, right? So that's what your customer base is looking at. That's what the Medicare base is looking at. They're going to see that on the Medicare websites, that you have 4 stars or you have 3 stars, and people can make their decision of where they go. Especially if you're trying to grow your practice or grow your business, it's important with that. So Saritha, if I follow up on that, what are our customers doing in 2021? What are they doing to help, alleviate some of this pain of this program getting this much harder?
Yeah, so there's a couple of, I think, pain points that people will experience. So a number of practices have been reporting, they're used to reporting this kind of quality reporting since PRS days, right? And some of the workflows that they're used to doing involve them basically, so for the reporting year 2021, they will do all of their quality reporting, say, at the end of that performance year, either December, January 2022, something like that. I think it's going to be much harder for groups to succeed with that kind of strategy. So like one of the values of using certain submission mechanisms like registries is that you can actually make a change to your strategy mid-year. You can make changes to performance. You can chase down the folks you didn't do tobacco cessation counseling for, whatever. I think with the penalty or the threshold being raised to 60 points, and also eliminating a number of bonus points from, say, promoting interoperability, requiring 50% of participants in an improvement activity to actually do the activity. There are all these lanes to kind of, I guess, assessing what it is you need to do to succeed late in the game. You can still kind of squeak through if you're not 100% prepared, right? Those avenues are shrinking if they're not already gone. So from a customer success perspective, what we want to do is get people informed, as early as possible the reporting year, that no matter what the size of their practice is, they need to get started with MIPS as early as possible. They need to consider the completion threshold. They need to know that they've got improvement activities covered by at least 50% of the providers. They really need to understand what their eligibility is, all those things. It shouldn't wait until late in the year, or even now timeframes. That's just not a winning strategy. So that's the thing I would emphasize the most. If you want to set yourself up for success, I mean, this is kind of true at any point, but just the ability to turn around is just not there for 2021 if you don't have a good sense that you can succeed earlier in the year.
I think a lot of, go ahead, Joy.
Yeah, well, I wanted to hop onto something that you had said earlier, but I don't want to interrupt you. So if you want to hop on that, I'll wait till the end.
I'm going to hop on real quick, and then we'll go to you. So what I was saying is that I think our message is being heard, at least by our customers right now. So in previous years working with this, a lot of people would wait until after they were done their submission, right? They'd wait until April, and then they go, all right, maybe we'll get started in May, and then the summer hits, and they're already behind on everything. we have never been busier in the first couple weeks of January with people signing up for 2021 reporting, wanting to track that information, wanting to get ahead. And I highly recommend everybody do that, because it is a competition in the end. There will be a certain percentage of people that fall above and below, especially as we go into next year and the year after. That's really going to be done, really make it more of a competition. And I think our customers are starting to heed to that and starting to get involved today to make sure that they're on pace for scoring well moving forward. I mean, look at 2022. The projection for 2022 is 74% is going to be the threshold for missing out on missing the penalty. So 74%. Think of what you scored in the last couple years. Know that it's harder. Know that the measures are harder. So it's time to get on the ball early to get yourself a jump on your competition. Sorry, go ahead, Joy.
No, sorry to kind of rewind a little bit, but you guys triggered something for me that I was just thinking. One, kind of going back to the idea of the reputation and the physician compare and whatnot, we're right in that bell curve of the baby boomers coming on to Medicare. And just one thing to keep in mind about your reputation is that when somebody says, okay, time to choose your doctor, CMS is basically handing them over to those websites to compare, to make those comparisons. And so it's really important to know that like your star ratings and your actual scores of each categories are translated into layman's terms so that anybody and basically their mom or their grandma could make sense of them and find a doctor based on the results. And I don't think a lot of people make the connection that it's essentially the MIPS program, that's how a lot of people actually choose and select their doctor. And then additionally, we talked about Medicare, we talked about the MA programs, but there's also the commercial payers. And so United Healthcare, for one, is a commercial payer that will actually tack on the incentive payment, and they will make their reimbursement rate in alignment with the CMS reimbursement rate on the positive side. They have avoided negative, any penalties, which is beneficial for folks. But if you're looking for, not just your Medicare reimbursement, but your overall compensation, including commercial, that makes a difference too. That's it. Those were my 2 points.
Sure. So I wanted to hop over into another question that we see often is, what was that impact of COVID-19 to the final rule? It seemed to me on the 2,000 plus pages that they had it there that almost every page had the word COVID-19 written on it somewhere. So what is the ability for us? What does it look like? What did COVID-19 do? How is it shaping MIPS MIPS and the value-based programs for 2021? Lauren, you wanna go with this one?
So I think the first obvious one is, again, telehealth. So I think CMS changed about 60 measures to include telehealth in the 21 reporting period. Some people may consider that good because you're really getting a better picture of care. Some folks find it more of a burden because now when you talk about workflows, you have to make sure that when you have a patient in a telehealth visit, that you have the appropriate workflow to capture those quality metrics. I think that some people jumped into telehealth, with their iPhone and FaceTime, and that was great because that's what we needed. But I think what we see is there needs to be more rigor in telehealth as we move forward. We've proven it can work. Now we need to put the appropriate controls around it. We need to make sure that it's aligning with good health care. We need to make sure that preventive care is happening appropriately as we move forward, even with telehealth. So I think that's a huge change that we're seeing from the COVID world. I can talk a little bit about, certainly for the ACOs, it's interesting in that it really is changing some of the risk scoring for patients. And there's a lot of concern around, for 20, actually, some folks fared really well in their value-based care programs because patients didn't use as much care. But I think we're going to see the repercussions of that going forward in a couple of different ways. I think we see it from the perspective of the amount of care that could possibly be needed in 21, both because of missed elective surgeries or whatever, also missed preventive care. And I think we're also going to see impact from the standpoint of maybe you didn't capture your ICDs, to create it's a whole, I'm going to talk in a lot of jargon here, but your ICDs that feed into your HCCs that feed into your risk weighting for your patients. And so I think that there's, I was at the JP Morgan conference last week, and there was a lot of talk around that, around how is that going to impact a lot of different value-based programs, including our ACOs.
Virtually. You were virtually at the JP Morgan one. Let's just
Yes,
make sure we all worry about you, Lauren. So, we want to make sure that everybody knows it was virtually.
Yeah, I did not get on a plane. I did not get on a plane and go to San Francisco this
year. Next year, hopefully. Next year, hopefully, for sure. So, Sarita, do you have anything to add to that?
Well, not a ton because we don't know a ton yet. I will say, judging from 2020, I will not be surprised if a significant percentage of people do attempt to fill out the extreme and uncontrollable circumstances waiver. I don't think that's even open yet for 2021. It wasn't when the final rule came out. They just mentioned that there would be a similar policy in place. So the fact that CMS has extended the 2020 policy through February 1st, the fact that COVID's not going away till at least the summertime. I mean, so I think we could see a number of entities that are significantly affected by COVID. I think that's gonna, be nothing like 2019 was, and even I would assume that it's less than the percentage of folks who are affected by it this year, or sorry, for the 2020 performance period. But yeah, I don't think that's just disappearing. So I do think that will affect that the budget neutrality of the program.
Do you think it's possible that, for 2020, they gave this blanket exception because, it kind of came as a surprise, everybody was affected, but now COVID isn't it's here. It's not as much of a surprise. People are adjusting. Do you think that if they do implement the hardship application or the extreme and uncontrollable circumstances, that they'll kind of make people prove that there's going to be some sort of metric to decide whether or not they qualify?
So on the 2020 application, there is that date range. You can request per performance category, and there are the date ranges to say, well, if it's going to be less than, the 70% of, if you can still meet the completion threshold, I think CMS will push people to report. But I do also think that they have an interest in being kind of as lenient as they can to support folks who are truly impacted by the pandemic. So we'll see. They didn't mention changes to that particular policy, but they also didn't finalize it. So they could be leaving themselves some room there.
Gotcha. Cool. Thank you. So I have two more questions for our team that I'd like to go over, but this is a great time if you have questions for our panel. Get them into me now so I have a chance to look at them so they can answer them as we go. The first one's at the top of our screen now about specialty measures. This has become an area of major focus as MVPs are coming down the line, and they're going to start really implementing more of a specialty focus when it comes to reporting your quality data and your quality information. But specialty measures are becoming more outcome focused, and the CMS is asking for a lot more than they have in the past for these measures. So Lauren, do you want to talk about that for a second?
So I don't know who wrote the slide, it wasn't me, but I wouldn't say that CMS is trying to make them challenging and require effort. I think what CMS is trying to do is really make them outcome focused and make them patient centric. And I think that potentially in some people's minds makes them more challenging and makes them require more effort. Versus our old checkbox, did the patient have a flu shot? Has the patient had a pneumonia vaccine? So yes, they probably inherently are more challenging, but that's not the intent. In fact, CMS talks about they're trying to make the measures less burdensome. They're trying to make them more digital. They're trying to really remove extra burden. And like I said, one of the things that I loved about Seema Verma was her, we're trying to reduce the burden, we're trying to have meaningful measures, and we're trying to prioritize patients over paperwork. And I think that you don't have to get rid of your slide. Don't be embarrassed.
I can't take full credit for that slide.
The context for the challenging and requiring effort, I believe, was QCDR measures. Specialists want measures that are most relevant to their specialty, but because they tend to be more outcome and specialty specific, they can be more difficult to report. I believe that was the context for that on the slide.
Yes. Sure, we'll go with Sarita's explanation on that one. I think I was taking it from being in a doctor's office, and it feels like things are more complex moving forward.
So I don't know if we're going to hit on MVPs later, or whether you want me to jump in with that at the moment.
Sure. Why don't you go? Yeah. Why don't you go over the MVPs while we're there? I'll go back to that screen. So you can go and start to talk, and I'll hit back to the MVPs.
So one of the things CMS is concerned about as we move into MVPs. So MVPs are MIPS value pathways. And if you go to the CMS site, even over the course of the last week or two, what you'll see is CMS is really starting to delineate, for 21, we are MIPS. And they're really starting to call that traditional MIPS. And then what you're going to see is the MVPs, the MIPS value pathways, starting to emerge in 2022. CMS is very, very committed to this. There was a town hall on January 7th where they spent the day talking about the program, talking about how they want it to be put in place. They see it as a transition into APMs, but it is MIPS. I mean, when you log in to our system or to any other system for 22 and you look at MIPS, you're going to pick your traditional 6 quality measures and 2 IAs and PI and cost as appropriate. And you don't pick cost, but cost will be applied to you. Versus the MVPs are much more defined. So they're going to pick 3 really solid quality measures. They're going to pick certain improvement activities that align with that, and then a cost measure or 2 that also align. And that's going to be the MVP. So it's just MIPS being packaged differently. And the reason I bring that up in the context of measures is because what CMS is demanding for those measures is that you want to make sure that those measures are like your most robust measures, because they're really evolving into, that's going to be the gold standard of star rating, of measuring provider performance. Not to say that there aren't a ton of unresolved issues around how this is all going to work, because I don't think it's all been firmed up yet, and there's lots of different nuances, the devil's in the details, right? So, but the idea is that we're going to pick measures that are meaningful, measures that are relevant, measures that really are focused on the patients, and define a tight package that we're evaluating our providers against.
And practically speaking, like as a clinician who's performing in traditional MIPS versus an MVP, some of the stuff is still the same. Like you're still going to need a security risk assessment. They have a foundational level that folks will still be doing their promoting interoperability with the same objectives and measures. But my understanding is that basically the menu options for improvement activities and measures essentially gets reduced based on your specialty. So instead of saying like, I'm going to choose any 6 from a total of 200, depending on your specialty, they're saying, okay, we think that you should report these 3. Does that seem fair, Lauren?
Yeah, it's almost like in the old days, the PQRS measure groups. I don't know if you guys remember that, where they kind of laid out, here are the measures, and, you know, pick a cohort of patients that you're going to report for those measures.
Right. We actually have a good follow-up question for this that I think hits one of our specialties. So do you see, hold on, the question just disappeared on me. Hold on a second. All right. Do you see regular MIPS reporting still being an option when MVPs are implemented? I think we talked about that a minute, but if you could go into that further. But in this case, they're asking about MVP framework and concerning with subspecialties like Dermal Pathology. They do only skin specimens. How would you expect a group like that to report on a regular MVP? I see lots of head shaking, so I'm going to go with my first head shake and go to Saritha.
So my remarks are contingent on them actually developing an MVP for dermal pathology, which would absolutely need to come first. But I do know, from firsthand experience with working with clients who are part of that specialty, that they often struggle to get enough measures to get much of a score in quality. With the changes to EMA rules, it becomes really hard to get a good quality score and be a dermatopathologist. So I would hope that that would actually be a great place where an MVP would actually be really useful and really helpful, because it would identify the 1, 2, or 3 measures that dermatopathologists can really report, and then align those with appropriate activities and cost measures. So I think I understand where that question is coming from. I would hope that that is where CMS focuses its efforts, so that reporting makes a lot more sense for specialties or specialties that are not well represented by 6 quality measures.
Right. So actually, and we could continue talking about this subspecialty group, but we hit something with MVPs with questions from the audience, and something that I actually am very interested to hear more about is what about your multi-specialty clinics? What about these places that have, different providers, different groups? You got a GI, you got a derm, a urologist, all working in the same tin. What are those guys going to do for MVPs? I see Joy smiling. Oh, Lauren's going.
Joy, you want to go for it? Sorry.
No, you go for it, Lauren. I think that you start.
So again, in the meeting that the town hall that CMS had, they were looking for feedback, and boy, did they get it. One of the big concerns is how do you manage those subgroups? The idea in theory is that all of your specialties will get to report the measures that are most applicable to them. And you'll have subgroups, and each subgroup will be able to report their measures and get scored on things that are really relevant to their practice and to their patients. Again, the devil's in the details. So do you roll all of that up into an average score? Do you give each subgroup its own score? Who goes into each subgroup? Do you have to qualify for a subgroup? Does a subgroup have to be predefined? Is the subgroup predefined before the beginning of the year? Does the subgroup need to self-nominate? Does the subgroup need to show their qualifications? What happens if other providers join the group or drop the group during the year? You get to re-elect at the end of the year. How do you benchmark this group? So there's lots and lots of undetermined TBDs around those subgroups. Again, great idea, good intention, good philosophy. We're still trying to figure it out.
That is a whole lot. I feel like I just signed my mortgage listening to that the list of things that you need to sign off on. Thanks. Joy, did you want to follow up with that?
Well, thinking of the details, I'm just thinking, yeah, they've got to change their whole system, the attestation portal, and how things are organized underneath the group, the TIN. And then how do you divide and conquer the work associated for each? Like you basically have a different set of workflows for different clinicians within the practice. I mean, I'm kind of glad to hear that they're putting it off a year, because it sounds like there's a lot of details to still work out.
So when we
Well,
were
it is a
first reading,
2022. It's a 22 initiative. They are currently putting together these MVPs for 2022. So one of my concerns as a registry is we're going to need to support it next January. And how are we going to do that when they're going to put together something in the proposed rule in July, it's going to come out in December, and then we're going to have to work like heck to put together the framework to support that.
All right, Sarita, did you want to add?
well, I would say like when we first heard about MVPs in 2019's, I think it was 2019's final rule, I was like, oh great, it's measures groups again, sort of, like a fancier version of measures group from PQRS. But like hearing that list of qualifications, I was like, well, it's like kind of the antithesis of measures groups if you're splitting out every subgroup in a 10. Like that seems like that's not. I mean, we'll see what they do, but it does not seem to that would lessen an administrative burden for a large organization. So that would be just my concern about that being a requirement. But I don't think we'll see requirements for MVPs anytime soon. There's too much, to work out there. So it'll be an option before it's required. If it's required.
We touched on something, and it was on the other slide around benchmarks. And as they change quality measures, if there's any kind of substantive change to them, a lot of times the benchmarks either get reset, or it sounds like may in some cases have to be in place in real time. Or what they're saying about the registry-based benchmarks. I have a legit question about that. Does that mean that does each registry have the same set of benchmarks, or HealthMonics is creating benchmarks for HealthMonics clients and other registries for their clients? Do you have an honest, legit question?
So I think we can develop benchmarks around to share back to our users. But in the end, CMS is going to assimilate all the data at the end of the year, and they're going to set the benchmark. So nobody will know what the benchmark is until after the fact.
Well, what's really nice about utilizing a registry like HealthMonics is that we have a large base of customers that are using our system that are reporting those measures, and we'll be able to give an idea of what that benchmark might look like at the end of the year because of, our percentage of patients that we have, or percentage of providers that we have in our system.
So I know that there was a preview sort of ability that CMS was wanting QCDRs, I want to say, to pick up. And then they ended up, I think, punting on that and saying, okay, not for 2021, 2022. Is that where you're referring to, Joy? Or is it in a different context?
Yeah, well, I know that it was in the proposed rule for 2020. It didn't get finalized, where they were talking about doing benchmarks in real time. And that was a red flag for me. I'm glad that it didn't get finalized, because it's really hard to track your progress when you don't know what it is you're tracking against. And yeah,
right. Yeah, we did have a number of discussions about, well, what would we, because you don't want to overpromise, right? So if your score is based on a benchmark score and you're setting your own benchmark score versus CMS's benchmark score, then that's going to change. So if I tell a provider that they're getting 9 points and it turns out they get 6 points, then that provider's not happy with me. So there's a lot of questions if we went that route where every registry has its own predictive engine for every measure. Yeah, that's a lot that you're asking your clients to bookmark in their head. Be like, just kidding, this isn't a real score. Just wait for the real one. That's tough.
All right. We could talk about measures all day long. I know we could all geek out over that for sure between this group here. I wanted to get to one other topic, and then there's a couple of questions from our audience that we'll see if we have time to get to. But the other topic is, we really didn't cover it that much on this call, and it's really interesting because I consider it one of the more important steps moving forward with MIPS, and that's the MIPS cost performance category. The impact of it is growing tremendously, 20% in 2021, 30% mandated by law for 2022, it's becoming a big chunk of what your score can be, and it's not something that you can report on. But what can you do? I'm going to start with Lauren on this one.
I thought I already went first.
Oh, okay, hold on. Then I will start with Joy on this one. I don't
Sure.
know. Saritha, somebody
Well,
go.
I'll start. I don't mind. So we start talking, one of the conversations we have with our clients is around how many of the total points are in your control, right? And for 2021, there's only 80 points that you can basically, based on your work and what you and your team do and the data that you collect, that you can 100% control, so to speak, to a degree, what your score is. And this other 20 these other 20 points, you can gauge based on past performance and whatever you have put in place so far, whatever kind of a handle that you have, like, wonderful. A lot of times people score really well and it's like, hey, I didn't actually do anything and I got the points. That's fantastic. However, for me, it's kind of it's the wild card of just like being a little bit of a control freak and not being able to actually know or predict with some true accuracy what it is. And coupled with the the threshold being 60, I'm like, okay, we can control 80 points, but I have to get at least 60 in order to avoid a penalty. Like, red flags show up for me for that. So I'm glad to know that you all have been working on a product that helps people get some insight into that. And I will stop there and let you take it.
Okay, I guess I'll talk. I feel the eyeballs. So Joy is right, and you couple that with next year, the threshold's going to be 74 points, and cost is going to be 30 points. So you can figure, okay, the reasonableness, you'll probably get half of those points. But first of all, I think it's important to understand which cost measures are going to impact you. And so we HealthMonics are going to start posting some of that. We've been working on understanding the cost measures in detail, how they get attributed, who they get attributed to, and certainly going to provide more feedback on that as we move forward. So that's number one. Number two is then to look at those measures. So if you're an ophthalmologist, for example, if you do cataract surgery, they're measuring you on the total cost of your cataract surgeries. And it's not just what you're doing, it's everything around that cataract surgery. So you really need to understand those costs. And it's unfortunate that we call it a wild card, because what CMS is trying to do, again, you look at MVPs, you look at quality. They really do. This all started from good intention. This all started from, we want to try to impact the quality of care, the cost of care. We're trying to make things more focused on what providers can control. Unfortunately, with cost, because we are looking at the total cost of care, be it for a patient throughout the year, in the case of the total per capita cost, or any of these episode measures, be them a hospital stay, sepsis, pneumonia, eye surgery, cardiac surgery. We want somebody paying attention to that total cost. And so CMS is pinning it on that doc. And so you really do have to pay attention to which measures are going to impact me, and then how can I control those costs. What we've done at HealthMonics is we've joined a program where we can get data for our providers, and we can simulate that cost score calculation. So you can go in and you can look at, here is, if I'm an eye surgeon, here's the total cost that's going to get attributed to my eye surgery. And I can look at what's going on. Is it the facilities around that eye surgery that are impacting the cost? And if they go to facility A, is it costing more than if they go to facility B? And that's where CMS is trying to go, is they're trying to get people to pay attention to that sort of thing. The construct is challenging though. I'll stop there.
Sure. Saritha, do you have anything to add to that one? There was a lot of conversation there. There's not much to add, but you could go on for hours on the cost category for sure.
Yeah, not particularly. Just to echo that, the managing risk is really, as Joy, that's basically what Joy said. If for you to succeed, managing risk has to be a part of it, and getting the unknowns as knowable as possible. That's what our Revlytics product is about. So we're trying to bridge the gap because there aren't a lot of tools out there to do that.
All right, great. All right, let's see. I want to at least share a little bit about what we do at HealthMonics before we go for the day. Our approach is conquering the value-based care. As you can see here, we're not only a MIPS company. We do data integration. We have our friends at chirpybird that do our consulting for our APM and our MIPS side of the business, help you with the SRAs and everything like that. And thank you, Joy, for joining us today on this call. And I highly recommend, as you can see, this is getting harder, of asking us when you give us a call about how you can work with Joy's team to do better next year. That's it, do better. That's our goal for next year, maybe our slogan for the year. We also have the ability to look into your risk score management, helping you out with those HCC scores and making sure that you are getting paid what you deserve for your sick patients. And then we also work with organizations to go over chronic care management. This is a look at what our dashboard looks like. If you have any questions, you can hit that contact at healthmonics.com. That comes directly to me. And then the phone number there goes to our sales team, as well as visiting our site. You can look at our webinars that we've done in the past, as well as our webinars for the future. We have a lot on there. We do have a 2021 final rule one that was out earlier this month that is a good resource and more of a webinar presentation with slides, tons of slides to go over and take a look at. Before we go, one question that came across actually from two different people was, did CMS talk about topped out measures? Because I know from my side, people are having a hard time choosing which measures to go for moving forward in 2021. What did they talk about? What kind of advice is CMS kind of telling people to deal with when it comes to these topped out measures? Saritha, looks like she has the answer on the tip of her tongue.
Well, I'm trying to think how I can say this in a way that honors CMS's intent. So I think CMS doesn't want people to use topped out measures. I think it's a disincentive. I think that's the purpose of topping them out, is to say, hey, get used to the fact that these aren't as helpful for you because they're going to be gone soon. So topped out measures to like the highly topped out measures that are capped at 7 points. It is the pathway to retiring a measure. So unfortunately, like the most to the point answer is pick another measure if you have one. And unfortunately, it is a way of gently de-incentivizing people from using it and then whisking it away so they cannot. So alas, we, in the product itself, we try to do a lot to identify so that you can quickly identify which measures are topped out so that you can choose other ones if possible. So if you're having trouble, that's finding other measures. That's a kind of a different and a tougher conversation.
And the detail around that is that if they are like highly topped out, 2 years in a row, you get a 7-point cap. And after the 3rd year of being highly topped out, they retire it and it's no longer an option to report. Is that correct?
I think that's the right timeline. Yeah.
Yeah, so we get a lot of that on our side. Is that I want to do this, I want to participate, but the measures I've been doing for years, my flu and pneumonia, the smoking, the medication list, measures that have been around since, before I was doing consulting 10 years ago, it feels like. Those are the ones that they want to do, and where I see the push towards is towards these outcome-based measures, where they really are taking a look at the patient care and seeing if the patient care can improve. And that's where the scores are coming from. That's where the bonus points are available too, taking a look at reporting more than just your 6 measures, looking at that 7th or 8th or 9th measure and adding those bonus points for high priority and or outcome measures can really help with your scoring on these. And then, making sure that you're doing the right things as we've talked about with HCC scoring, to make sure that your complex patient bonus is where it needs to be, and where your cost score can have the largest impact is making sure that the sickest patients are categorized as the sickest patients. There'll always be the surprise, but I think that's where, if I was to look at ways to improve what I'm doing, it would be the correct measure selection and workflow in your office, and understanding your billing, your ICD-10s, and your HCC scoring. That's where I think it's going. That's what CMS looks like from a measure standpoint. What they're pointing at is to make sure that patients are getting healthier at the end. And that's the point of this program. It's not a click program like we've talked about for a long time. Did we go out? Is everybody still here?
Nope, you're still here, but I can't see you anymore.
Oh, there you go. It's back. All right, go for it. Does anybody have any parting comments they would like to make? And otherwise, we'll get out of here. And please, everybody, download the slide deck. I also have some other information on there that I will also be sending in an email shortly after this is done, so you can rewatch this awesome video, and we can we can go forward. But let's go with parting shots. I'll start with Joy.
Well, I just think this year is going to be tough. The sooner that people can get started, the better off that they're going to be in the long run. And we're at chirpybird here to help. That's what we do. So on the topic of helping people decide what measures are right for them, and making sure that their staff is trained and on workflows, and that their technology is kind of customized to the degree that it can be to collect the right data, that's our sweet spot. So reach out. We're happy to help.
Got it, Joy. Sarita.
I'm looking forward to seeing what the MVPs end up looking like. I think that if they get that right, then you will have specialties and subspecialties who really have a much better, more meaningful engagement with the program. So I think there's a lot of things to look forward to being a better fit for folks, and hopefully we all get it right.
You got it. And Lauren, parting shot?
So I think that CMS is trying to converge in terms of the technology. We've got MVPs, APMs, and MIPS, traditional MIPS, all now running through registries. I think that that's good in that it's consistent and you can get some insight into your data. So I think that that technology convergence is good. And I also think they're trying to develop a path into more value-based payments from MIPS. So as we get better at MIPS, per se, we can start really looking at things that matter in value-based care, which is quality and cost, and focusing on the patient.
You got it. Thank you very much. Great job, team. This was a great webinar. It is now time to go. We look forward to you guys joining us again for our next webinar. Look out for our February webinar list coming up soon. And if you have any questions, our contact information is right there, and we are waiting for you to give us a call. Talk to everybody soon. Have a wonderful day.
Thanks, Mike.
Thank you.
Thank you.